And then,
And yep, you're good. And then just press, presentation.
right,
Yep, perfect.
perfect. Okay.
Great. Thank you so much again for joining us. And thanks for everyone logged in. We're up to got 80 people here with us.
Oh, perfect.
Yeah.
All right. So what we'll be talking about, of course, today is posterior urethral valves. We'll start out simply with a little bit of embryology and then work through the entire talk. In the middle of the talk is a video which runs about 5 minutes. It'll give you time for a bathroom break, an extra cup of coffee or whatnot. But it is a video, and we can, if somebody chimes in, let's skip ahead, then we can certainly do that. The only other thing that I want to mention that we're not going to probably touch on today, unless we have extra time at the end, is prenatal intervention. It's a talk in and of itself. I have included my slides at the end of this talk for your perusal if you would like that update, and certainly I'm happy by email to answer any questions. So we'll start out with embryology. So as you know, the cloaca gets divided about week 5 to 7, and it's the migration of the orifices of the Wolffian ducts from the anterolateral position of the cloaca to Muller's tubercle on the posterior wall of the UGS, which is important with regard to valves. This migration path is normally lateral and posterior. The normal remnants leave the inferior urethral crest on the floor of the posterior urethra and the plicae colliculi. When the insertion of the Wolffian ducts into the cloaca is anomalous or a little too far anterior, as we think, the migration then results in the formation of abnormal ridges, which are what we term valves. So what are valves? They're a hypertrophy variant of the inferior urethral crest formed by the insertion of the distal ends of the Wolffian ducts, again, into the anterolateral walls of the cloaca. The actual leaves arise from the viri and then course anteriorly and fuse in the midline. I use my hands for this. And the valves are seen just proximal to the external sphincter. And that proximity is important with valve ablation, and it's important to distinguish the two structures and only ablate the valves. Hugh Hampton Young published in the Journal of Urology in 1919 these schematics of the type 1 valves, which show the leaflets emanating from the viri posteriorly and meeting in the midline at 12 o'clock. Type 2s are not of great clinical importance. Type 3 are an annular abnormality with a central area, and these can be located anywhere within the posterior urethra. What do we know about valves as far as the detection rate? They're detected in 1 in 12 in 1,250 ultrasound screenings. About 50% of valves are detected prenatally. And while I'm on that fact, then what about the other 50%? The other 50% are usually detected through 25% with urinary tract infection and 25% with other findings, which we'll discuss as the talk proceeds. Posterior urethral valves account for about 10% of obstructive uropathy diagnosed prenatally. The incidence is 1 to 2 in 10,000 live births. In the US, we expect to see 300 to 500 cases annually, with about a third of these going on to end-stage renal disease. Posterior urethral valves may be associated with chromosomal 11 and copy number variants, since the affected SIBs share a partial duplication in the short arm of chromosome 11. So what about the pathophysiology of valves? This schematic shows the vicious cycle involved in the development of the valve bladder. That's a term coined by Mike Mitchell many, many years ago. You start out with partial bladder outlet obstruction prenatally. You develop some mild detrusor hypertrophy and high voiding pressures, preserving near complete bladder emptying early on, and that's the compensated phase. Then the bladder wall undergoes remodeling with collagen deposition and hypoxic changes from stretch, and this then leads to decreased compliance in the bladder, increased post-void residuals, and elevated stored pressures. There's increased renal pelvic pressures leading to more tubular damage, which then leads to polyuria due to renal dysplasia and glomerular and tubular damage. The kidneys just can't concentrate. The bladder can't keep pace with the functional demands, and then the voiding pressures become elevated. You have elevated resting pressures with increased post-void residuals, hydronephrosis, and further renal damage, and that's the decompensated phase, and this just keeps going on and on. I did some work with Andy Friedman, who's at Cedars-Sinai many, many years ago on valve bladders that he brought to us from sick kids, and showed that there is increase in muscle, but equal increase in collagen. So it's just a lot of everything that develops over time, but it isn't like the myelobladder, which is totally disorganized. The prenatal ultrasound findings include echogenic or more white kidneys as compared to liver, cortical cysts, lack of corticomedullary differentiation, which you can see here, hydronephrosis, hydroureter, distended bladder with or without oligohydramnios, and symmetric thickening of the bladder wall. We talk about symmetric thickening because there's asymmetric thickening in prune belly syndrome. The keyhole sign has been described to help us with the phenotype prenatally. That's seen in valves and urethral atresia. It is not seen in prune belly syndrome, reflux, neurogenic bladder, the megacystis microcolon syndrome, which is fairly rare, and cloacal anomalies. Fetal MRI, I've put this in here. This is a very old fetal MRI, and we really can't get a lot of information from it. You see a big bladder and dilated kidneys. The ureters may be hiding behind the bladder, but with new and improved MRI, we can even find a keyhole sign in the studies, but usually unnecessary as an adjunct. Sorry, I've got a fast finger. So what about the mortality, morbidity involved in these prenatally diagnosed cases? There's 30 to 50% mortality, and if oligohydramnios is present, that it's as high as 77%. If oligohydramnios is present in the second trimester, this portends a poor prognosis. Fetal obstruction affects lung development, and it's important to remember that the kidney or metanephric urine production starts at about 12 weeks. The fetal contribution to amniotic fluid begins after 18 weeks. And normal amniotic fluid is essential to bronchial branching, especially during the critical canalicular phase between 16 and 28 weeks. Oligohydramnios is associated with pulmonary hypoplasia and an arrest of normal lung development, resulting in abnormally low numbers or size of the bronchopulmonary segments or alveoli. And that's why this time frame is so important. And as I said, we're not going to get into prenatal intervention, but the time frame is very important to restoring amniotic fluid. If you look at an interesting study by Mark Johnson and the North American Fetal Therapy Network group, there are about 11 centers in that group. This study was published in 2018. They looked at fetuses with lower urinary tract and normal or slightly reduced amniotic fluid who were thought to have a better prognosis. So these centers evaluated the outcome of lower urinary tract obstruction with normal AFP at mid-gestation. Of the 32 patients with lower urinary tract obstruction and normal AFP at 24 weeks, followed at these centers for a period of about 5 years, 56% of them had a final diagnosis of posterior urethral valves. So making the diagnosis is sometimes hard and difficult because the phenotype is not always straightforward by ultrasound. Gestational age at delivery was 37 plus or minus almost 3 weeks, and the mean creatinine at discharge was 1.2 plus or minus 0.8 milligrams per deciliter. Renal replacement therapy was needed in 32 with intervention early, with the median age of those babies being 3.75 months. So how do what is the clinical presentation of valves in prenatally and also postnatally? Abdominal mass is certainly one. Ascites is seen in this X-ray here, KUB, and respiratory distress and spontaneous pneumothorax. Early demise is usually secondary to pulmonary hypoplasia. Infants in the old days, when I was a resident, came in with urosepsis, dehydration, electrolyte imbalance, and failure to thrive. That was not unusual in 1982 when I was in urology at Johns Hopkins. Toddlers and school-age boys, urinary tract infection, and persistent problems with incontinence, nocturnal enuresis, or voiding dysfunction. So what is the first steps in management of the neonate? One, their respiratory status, of course, is addressed. From the urologic standpoint, we drain the bladder with a 5 French feeding tube, and we never put in a Foley catheter since the balloon can obstruct the ureteral orifices and also cause bladder spasm. We correct the fluid and electrolyte imbalances. They are often have a metabolic acidosis, polyuria, and antibiotics are instituted, usually amoxicillin. And then there's serial monitoring of the serum creatinine. And the creatinine should really drop in a couple of days. It first reflects that of the mothers and should not be on uptrending. What are the postnatal sonographic findings? Well, abnormal echogenicity is seen here. Cortical cysts, there's some small cysts seen here. Lack of corticomedullary differentiation. We can all see that these are calyces, not medulla, and there's no medulla seen. Hydronephrosis, hydroureter, elevated bladder neck, dilated posterior urethra, and bladder wall thickening. The bladder wall is thick when distended and measures 3 millimeters, and if the bladder is empty, 5 millimeters is considered thickening. I'm going to make one point now, and that is to never forget the following. Just a small anecdotal story, but it stood the test of time. I was at the city hospital, and Bob Jeffs asked me, well, how are things going out there? Are you seeing anything interesting? I said, well, you know, they're calling us for medical renal disease. He says, what? Well, tell me about the patient. And I went on to say that the patient had an elevated creatinine, but no hydronephrosis and pretty bad looking kidneys. He said, well, what did the VCUG show? And I stood there, of course, dumbfounded. And in fact, this baby had valves, and there was no dilation because the urine output was so poor and the kidneys were so bad. So when spontaneous pneumothorax, I forgot one point there, that the baby had spontaneous pneumothorax, that is a buzzword even to this day when patients tell me that their child had a spontaneous pneumothorax. I've not picked up another valve that way, but very important to remember that hydronephrosis is what we all remember, but sometimes the kidneys are just so sick, they're not hydronephrotic. VCUGs, they are classic findings, but you need to make sure that your radiologist is going to give you the proper study. And that is that they not only fill the bladder, but that they remove the catheter so you can view the entire urethra without the catheter in place, or at least pulled back into the anterior urethra. The valves appear as sharp, perpendicular, or oblique lucencies as seen here. You have a dilated, elongated urethra as seen here, trabeculated bladder with diverticula and cellulae, and there is bladder neck hypertrophy seen here. What you don't see is what's hypertrophied, and reflux is seen in about 50%. We'll talk a little more about reflux in a moment. I've put in this slide about Prune belly syndrome so that you don't get this wrong, although there is not a radiology section anymore, I think, on the boards. But nonetheless, to absolutely know that this does not represent valves, even though there's a dilated posterior urethra, because of course Prune bellies will have hydroureteral nephrosis and often are mistaken prenatally for valves. And again, a dilated urethra here, and I've just put a valve urethra back in just as a reminder. Some patients will have urinomas considered pop-offs. Many can be observed. This kidney is decompressed. It's a sagittal view, and the urinoma is sitting subcapsularly. And here's another subcapsular urinoma. Most of them do not need to be addressed unless there's increasing size, increasing serum creatinine, infection, hypertension, or parenchymal compression. And they can be addressed percutaneously or primarily percutaneously. Vesicoureteral reflux is present again in 50%. It's not a predictor of renal function. 20% resolve after the outlet obstruction is relieved and may be related to the function of the involved kidney. If reflux persists, this may definitely reflect bladder dysfunction. So let's talk a little bit about pop-off valves. Reflux is considered one, a diverticula, large diverticula, a patent urachus, and urinomas. We don't see many patent urachuses with valves, primarily prune belly, but occasionally with valves. These are thought to protect the bladder. So when a study was done many, many years ago, they of 71% with one or more pop-offs, 87% had favorable urodynamics. Only 55% of the patients without a pop-off had favorable urodynamics. And of those patients without a pop-off and unfavorable urodynamics, 5 of 7 underwent augmentation cystoplasty. It's certainly my bias to know that when I see a pop-off, those patients usually have a better looking bladder, but certainly not always. VURD syndrome is an important one to know. It's valves, unilateral reflux dysplasia. The kidneys are non-functioning. This non-functioning unit acts as a major pop-off, and we thought it was a good thing, but a study back in the late 90s showed that 67% of these babies will have initially normal creatinine, but only 30% will have a normal creatinine by age 8 to 10 years. They can be a source of infection. They may need to be removed. One needs to consider using the ureter as an augmentation for small bladder capacity or a bladder with decreased compliance. And the important point also is that if you're leaving that in place, and you think that it's a great pop-off, you can't be cavalier about not following carefully the contralateral non-refluxing kidney, because these are at high risk for scarring, and of course, close follow-up is recommended. Treatment options, primary valve ablation. I've put in primarily the large letters, and as you can see toward the bottom of the slide, vesicostomy and supravesical diversion. We use these less and less and less, but they are still in our armamentarium for some special infants. Primary valve ablations performed at 5 and 7, and I happen to really like the 12 o'clock position, but we do the leaflets initially at 5 and 7. You can use a cold knife, Collins knife with diathermy, Holmium laser, a wire through a 3 French catheter, Bugby 3 French, or my favorite tool is this little ball that is 180 degrees turned on itself. And I use the Wolf happen to use a Wolf cystoscope. Storz is also excellent, and only the cutting current is used. Studies have shown it really doesn't matter if it's hot or cold ablation, so to speak. But what I like about this little ball electrode is that as I'm working at 12 o'clock, or I should say the residents, now that we are able to do this indirectly, and you form a trough at 12 o'clock, and then you stay in the trough, and you don't wander. But then when you see the pink fibers of the urethra, then you'll get a little bit of bleeding, and then you can use a little bit of coag with this ball to take care of that. I leave a catheter in place, and I'll talk about post-op follow-up, but I am probably the only human being, maybe even in the world, that does the VCUG the next day. It only takes one case, it was from elsewhere, who thought they had the valve ablated, and then a child moved from one area to another, and I couldn't understand why they were doing so poorly. Of course, we had been doing so poorly, and we got a VCUG, and they had residual leaflets. So I never overestimate my ability and always get a simple VCUG the next day. Studies have shown varied outcomes. Back in 1996, Kim from Downstate showed no difference if you did any one of these procedures or how you did them. And Claire Close back in 1997, it's in Seattle, showed that, felt that ablation was superior. There is one diversion that is worth mentioning, and that's a sober auntie ureterostomy. I have an N of 1, so it's not done very often. It's performed at the time of valve ablation. It's rapid, and you are able to decompress the upper tract by having a side port here, a ureterostomy, and then you do a end to side anastomosis, and then the urine has the ability to drain into the bladder so that the bladder is not left defunctionalized. And we did that when a little guy whose creatinine rose to 3.5 and stayed there, and it was a great way to temporize. This, let's see if this works. Give me a moment. If it doesn't, then let's go on. It worked at home, but it's a video, so maybe it'll work on a smaller scale. Pre and post valve ablations, appearance of the urethra. Well, here's the pre-op study. And if you look carefully, the tube is in, okay? But I can see that there's just a commissure here, and this is open. And of course, 24 hours later, there's going to be edema. There's going to be residual posterior urethral dilation, and that may persist for many, many years. But you have a sense that you've gotten the job done, and I think that it's worth doing. You have to get your catheter out anyway. You might as well put some contrast in it and do a fast VCUG. Complications of valve ablation are not many if you're careful, but you do need to make sure you've done a complete resection. Incontinence can occur, especially if you violate the bladder neck and external sphincter, and also long-term urethral stricture. It's not a huge area, although the posterior urethra is dilated at that time. But we are always very careful of identifying the verumontanum and knowing the ejaculatory ducts are close by. Interestingly, I'll make an aside that long-term fertility is not a big problem with these folks. So we must be doing something right with regard to staying away from the ejaculatory ducts. Prognosis. So for many, I've had this slide for so many years, and the number changed from 0.8 to 1.0. But importantly, the natal creatinine at a year needs to be 1 or less than 1. The lower the better, of course, and that's associated with good prognosis. When it's greater than 1, it's usually associated with progressive renal failure and the need for replacement therapy. So this is hot off the press. I have had some time to read the journal. This is April 2020. It shows it was a randomized study showing the effect of looking at the effect of early oxybutinin treatment on posturethral valve outcomes in infants. There has been a lot of anecdotal use of oxybutinin. We've all used it from time to time in various settings when we're concerned about the appearance of the upper tracts, but we know that the valve resection has been complete. This trial involved 49 infants under the age of 12 months of age, and they all had undergone primary endoscopic valve ablation. 24 patients were randomized to oxybutinin using this dose, 0.2 milligrams per kilogram, which is the standard dose, given 3 times a day until they were either potty trained, versus the 25 patients who were in the observation group. The study endpoints were serum creatinine, estimated GFR, decreased hydronephrosis, reflux resolution, febrile UTI, and potty training. So 5 infants needed to discontinue their therapy because of adverse side effects. Facial flushing, as we know, is a normal side effect, but it was stopped in 2 children. Bladder and upper tract dilation appeared to worsen in 2 children, and cognitive changes in 1 patient. And so the drug was discontinued. Early oxybutinin was shown to improve hydronephrosis and reflux. It had no effect on the incidence of febrile UTI, completion of potty training, or the age at which the child potty trained. Nocturnal bladder decompression is also another part of our armamentarium, and in kids with hydronephrosis, hydroureter, and incomplete bladder emptying despite valve resection. We want to avoid this vicious cycle and the development of valve bladders caused by chronic overdistension during sleep due to polyuria, impaired bladder sensation, and residual urine. So we ask parents to place a catheter. It's not such an easy ordeal because these are sensate urethras, high bladder necks. Sometimes it's difficult to pass the catheters. And frequent nocturnal double voiding also can be an alternative to catheter placement. Chronic hydronephrosis is improved or resolved in this study, and creatinine improved in about 1/3. This was a study out of Steve Koff. He was always a great innovator, and this is we still use this in many different types of hydronephroses, valves, and other types of patients. Posterior urethral valves, again, we see this prenatally diagnosed, and we take care of the infants postnatally, but some infants will present at a later age or during childhood. They are managed in a similar fashion. They will undergo primary valve ablation. It's not been necessary to divert them in any other way. But the key for all of these patients is really lifelong urologic and nephrologic follow-up. It's really, really important. Many of these patients are lost when they seemingly are doing well, and it's important that they stay connected to us and or urology lifelong. I want to take a moment to just make a comment about the drained bladder, which is pertinent for probably all patients with valves. So after you drain a valve bladder, it's still palpable. It isn't enlarged up to the umbilicus possibly, but it's still palpable because of its thickened wall. And so sometimes when we're asked to see patients and there's hydroureter nephrosis prenatally, we may not know much about the patient. We really in our hearts don't think they're a valve. Do go by and do physical exam. Not only percuss the lower abdomen, but in a newborn, you just feel around the rectus. There's no fat. Feel around the rectus muscles. And I can still remember watching Bob Jeffs do this, and each of us feeling a valve bladder with a catheter in it. So next time you have a valve, please do physical exam. We forget that. It's really a still important skill. Let me make sure, yes. So prognosis in these patients, there's many studies. There are so many studies on prognosis, but it seems that we've come to agree that it's not related to the age of diagnosis, initial management, reflux status, urinary tract infection status, or hypertension. We do know that it's all about the bladder. Favorable prognosis occurs when daytime urinary continence is achieved by age 5. Certainly the bladder is a reflection of this whole problem. So that is really something to hang your hat on. Most of the pop-off mechanisms have been found to be helpful for the most part. What about delayed presentation of posterior urethral valves? There were 2 papers that came out a number of years ago. This manuscript had 47 patients, aged 5 to 35 years, who were found to have valves. They presented with daytime incontinence, urinary tract infection, and voiding pain. The hydronephrosis was found in 40% and reflux in 33%. The creatinine was increased in about 1/3, and 10% had end-stage renal disease. If a VCUG was performed for only abnormal sonos or urinary tract infection, 30% would not have been diagnosed. So it's a broad statement about recommending VCUGs in boys with voiding complaints, especially associated with daytime incontinence or urinary tract infection. Our ultrasound has improved considerably, but certainly when in doubt, a VCUG is certainly indicated. Another study, similar study about delayed presentation in valves looked at 70 boys, mean age 7.46 years. They had dysfunctional voiding. The most common signs and symptoms were nocturnal enuresis. Gosh, how much nocturnal enuresis certainly do we all in pediatric urology see? Urinary frequency. I write a lot of ditropan for regular kids. Urinary tract infection or microhematuria. So we need to always think outside the box. In addition, despite their adequate resection, once they were diagnosed, 63% had persistent voiding dysfunction. So what do we know about the urodynamic patterns? In infancy, the bladder is usually hypercontractile and has low bladder capacity. During the first 3 years, there's instability and emptying difficulty. Small frequent voids usually occur, and post-pubertally, they get, shall we say, burnout, increased bladder capacity, and 50% have either poor detrusor contractions or myogenic failure related to polyuria and also related to that initial schematic showing the vicious cycle. And so what do we know about urinary incontinence in some of the older kids? 50% of boys with valves have ongoing daytime incontinence into late childhood. Significant urodynamic abnormalities were present in about 55% and may persist following relief of bladder outlet obstruction, including myogenic failure with overflow incontinence, uninhibited detrusor contractions, high pressure voiding secondary to persistent valve leaflets, stress incontinence, and as coined by Mike Mitchell, the valve bladder syndrome. And that includes that really is similar to what we think of as a non-neurogenic neurogenic bladder, poorly compliant bladder from fibrosis due to chronic obstruction, and it can lead to secondary ureteral obstruction with worsening hydroureteral nephrosis if the bladder pressures are greater than 35 to 40 centimeters of water. You can start with treatment using anticholinergics, but then many of the patients may have a better urodynamic picture with regard to compliance and overactivity, but they will require intermittent catheterization usually for voiding. I am not a big Valsalva fan. I always say that Predate and Valsalva all went out with the Etzel. None of you are old enough listening to know what the Etzel was, but Valsalva is, it's rare that everything lines up to empty the bladder well with Valsalva. Empty the bladder efficiently and effectively. Augmentation is still a part of the armamentarium, and a catheterizable stoma can be added to that for ease of catheterization. In my 30 years here, at 26 years here, I have never augmented a valve. So I'm not sure how important it is, and most of the kids do well if you just work on it, and they work on it. Not all, but many. Urinary incontinence into adulthood. So that can be multifactorial. There can be sphincteric injury, overflow, overactive bladder with small, probably small capacity or functional capacity bladders, reduced bladder sensation, nephrogenic DI. It causes frequent voiding and nocturia, voiding dysfunction. And so it's really important before one does or considers doing a bladder neck incision is one, a trial of alpha antagonists, or with your urodynamics, it's a must to document these elevated voiding pressures with a closed bladder neck during the voiding phase. You really want to be careful about cutting the bladder neck. Urethral stricture is possible, but not common. So let's talk a little bit about end-stage renal disease and renal transplant. Proteinuria in infancy is related to a worse prognosis. Hyperfiltration leads to proteinuria and focal segmental glomerulosclerosis and renal failure. So when you look at boys with valves and proteinuria, 79%, it was found in 79% with chronic renal failure versus only 17% had proteinuria and normal renal function. After age 5, bladder compliance and stability were more favorable for transplant. Graft survival, patient survival, serum creatinine in boys with posterior urethral valves were equal to those without a history of valves due to more meticulous attention to bladder dysfunction and its treatment. In valves with, there was a study that was performed fairly recently with a small number of patients, though, that had undergone augmentations, and they were concerned about the effect of chronic infection in patients who were immunosuppressed. And they found that it really did not negatively impact graft function or survival versus that of controls. In the Journal of Urology in the last 2 or 3 months, there is an article that somewhat disputes this. It says that infection is bad, but interestingly, there were more infections in the non-urologic transplanted patients than in the urologic transplanted patients, and they did not look at augmentations specifically. So that story may still be told, but I think that these words, meticulous attention to bladder dysfunction and its treatment, is really the key to this talk this morning. Lastly, long-term risks of end-stage renal disease. In 2011, they reported the outcomes in almost 200 patients with valves over a very long period of time, very long period of different treatment times. The median age was 31 years, and 23% progressed to end-stage renal disease. The lifetime risk for end-stage renal disease in this cohort was almost 30%. The time to progression to end-stage renal disease correlated with the lowest serum creatinine value during the first post-op year. And of 44 patients progressing to end-stage renal disease, almost 70% progressed before the age of 17 years. So many studies have suggested it's a lower stage, the growing stage, the adolescent years that are the game changers for many patients. 31% of the patients were older than 34 years and did not have end-stage renal disease. And I'm going to skip down to this line that says no patient progressed to end-stage renal disease after their mid-30s. So that's a good fact to know in patients that you've been following. Increased renal risk of end-stage renal disease was associated with early presentation, pneumothorax, bilateral vesicoureteral reflux, and recurrent UTI following valve ablation. So let me just see, I will take 4 minutes to just talk briefly. I'll just talk very briefly. First of all, a little bit about prenatal intervention. I'm certainly not the expert, but have certainly read a lot. As you know, sometimes there's the oligohydramnios really doesn't let you know too much about the fetus to begin with. You need to determine the gender of the patient before you start intervening, because obviously valves only occur in males. There are associated anomalies present in 17 to 30% of fetuses with obstructive uropathy. Most of you who are residents or have taken your boards or taking your boards need to know these prognostic parameters here. They'll be in the slides and they're in every major textbook for poor prognostic parameters, and you just need to flip the greater than to a less than sign for the good prognostic parameters. And as you know, let me skip that, sometimes you need to do serial measurements because the first measurement may show, shall we say, old numbers, and by infusing saline or to receive the fetus, or doing the vesicocentesis 2 or 3 times at 48 to 72 hour intervals, you may determine that the fetal renal function is actually favorable, okay? So what I want to come down to is there are many complications of all of these interventions. The UCSF treatment algorithm is, I think, really stood the test of time as to what to do and when to progress and when to try to mature lungs and early deliver. I mean, we try not to trade early delivery and prematurity so that you really need to walk a fine line. But what I want to just move into is just a note about the Pluto study. So people were doing viscoamniotic shunts, but there was really a lack of evidence regarding fetal drainage. And the Pluto trial was a randomized controlled trial comparing the effects of intervention versus no intervention. Long story short, the data was not as good as we would have liked because they had trouble enrolling patients. But the data suggests that improved perinatal survival will occur with intervention, but there was unfortunately no difference in the incidence of end-stage renal disease. And that was the conclusion that Holmes and Baskin came to many, many years ago from the UCSF data, originally from the Harrison group, that we get these patients to survive, get them to birth, but the incidence of end-stage renal disease really isn't affected. Fetal endoscopy has been a plus. We're now able, they are able to do this with expertise, and it helps really with the determination of the phenotype, so you know if you're dealing with a valve or not. So that's one important issue. It has been shown that fetal endoscopic ablation does have probably a little edge when not only survival rate as VAS does, but it also may have an edge on renal function, not real function, when the original studies were looked at. The folks at Baylor, we should keep our eye on them. They are doing some wonderful studies trying to really stage valves and in order to determine who really should get a shunt. So we're not mixing apples with oranges and pears. And I think that once that is done and looked at more carefully, that shunting may be back in vogue and really have greater success with regard to possible improvement in renal function instead of taking all comers. So this staging has been proposed. But I think that's pretty much it. I've summarized these. I left the slides pretty beefy so that you can read through them without just a few words and go from there. Nothing. There's no free lunch for any of these interventions, and so you really need to carefully select patients if you are going to intervene for oligohydramnios and bilateral hydroureteral nephrosis and distended bladder. I think that's it. Good.
Thank you so much, Dr. Shapiro. That was a really excellent talk. Great review. Like I said at the beginning, this is a super high yield topic for in-service exams and board exams. Those pictures you showed of the keyhole sign, I've seen multiple on multiple in-services. And the other thing that tends to come up are the stages of bladder dysfunction as children age with posterior urethral valves. So your overview of those was great. There are a couple of questions that have shown up in the chat, and if anyone has any more, they can put them in there now. One person asked, what is the role of CIC training before transplant plus or minus augmentation in posterior urethral valves? What do you tend to favor, and what do you think about augmentation before transplant or augmentation after transplant, et cetera?
We have the patients that I've augmented prior to transplant have not been valves, actually. And we have a fellow, he's my oldest patient in my practice. I met him as a teenager. He had lupus, presented with lupus encephalopathy, and I augmented him prior to his transplant. The transplant's now so many years. So I don't think that every patient going, the numbers in that augmentation study were pretty low. I mean, I'm 30 years and I've not augmented a patient. I love to operate. It's not like we haven't augmented people. We're doing so many less because of Ditropan and Ditropan XL. And I think because we have such better pharmacotherapy that we're doing much better. I don't know maybe it's something in the water in Brooklyn, but we have one patient in 26 years at NYU in Bellevue. Bellevue is my big valve group because they come in from many of the HCC hospitals, and they come in threes usually. So, but nonetheless, most of those kids are progressing with their potty training, and only one is actually on intermittent cath. So I don't think there's a lot. I mean, I think if they didn't need intermittent cath pre-op, there's unlikelihood that they'll need it post-op.
Yeah, great, thank you. Two people actually asked about what are your criteria for proceeding to vesicostomy, and if so, choosing between a vesicostomy and a ureterostomy in cases where valves are either unable to be ablated or there are remnant valves.
Right. So, we had a prune belly recently. It was the last vesicostomy I've done in so many years. I think with the instrumentation, we're pretty good. So if we get a little guy, like we have one right now who's, a 29-weeker, and now we're just getting him to just grow, and usually by 36, 37 weeks, we've been able to get the 9 French scope in the urethra. If I'm not mistaken, and I'm not here to sell Storts or Wolf or anything else, some of the companies, you got to look at the optics. May you rest in peace, but I don't know if many of you remember Gordon McClory. He was wonderful, and I learned about the Wolf scope, and it revolutionized my life in doing valve resection. And this was before indirect vision. So I think that the need for vesicostomy is only if you can't get your instrument in and you really just want to move forward and not send them back to the NICU and bring them back, 3 weeks later. So to move them along, I don't think that we did many vesicostomies because of the instrumentation years ago. I did, and I think that we did well with them, and we closed and did the valve resection. The kids did reasonably well.
That's great to hear. And then one last question is, what is your protocol for antibiotic prophylaxis in these patients?
Yeah, I keep people. I'm a little heavy-handed on the antibiotics, but I came from the continuous antibiotic prophylaxis folks, because I also I was the generation that learned from Gene Smellie, Smellie. Back in the 70s of treating each infection as it happens. When you look how bad these kidneys are to begin with, they don't need another hint. They don't need a pyelonephritis. So if I can do my best to avoid that, plus the fact most of our valve population is uncircumcised, and ethnically, they don't want a circumcision. They want to look like their brother and their dad. So I'm not, interestingly, I'm not a big foreskin evangelist with regard to circumcision in any part of my practice. And I think that I do know that it does certainly affect this, but only once in my career have I recommended circumcision. That was with massive bilateral grade 5 reflux. Mm-hmm. And I really thought that was the time to do it. But I think that if you keep them on preventative, we've not seen the foreskin playing a huge role. I think if we took them off, they would be at higher risk. And the other thing that I do with actually all my kids who have, all these kids, anybody who's got a pyelonephritis at an early age, we get them on betamethasone cream, and we start, doing foreskin manipulation, so to speak, not forcibly, but with the betamethasone cream, because if you're able to expose the inner prepuce and get it cleaned up with each diaper change, you may be converting that patient to a more circumcision infectious status. And so that's part of the regimentarian versus circumcision. Also, the other thing I want to just comment, of course, they could also always be circumcised at another time. But after the valve resection and passing of the scopes and looking this, that, and the other, the prepuce is pretty worn out. So, and some of these babies are small. And so they're not getting circumcised in the hospital. And we don't really want to put them to sleep for another operation.
Yeah, that makes a lot of sense. Well, thanks again for an awesome lecture and amazing review of this important high yield topic. Thanks for joining us. If you want to